Hey guys, this is Vicky. I'm hopeful that you already listened to the first part of this lecture, which was slides 1 through 16. Now what I really want to go into is some of the key ethical principles. So there are some key terminology that you really should be aware of for your nursing career and also to be able to provide ethical care for your patients. The first principle is autonomy, which just as the slide says, that it's the personal freedom and the right to make choices. So what it's really, we're kind of looking at provision 1, it's the respect for people. So we know that people are free to form their own judgments and actions as long as they don't infringe on the autonomous actions of others. Some of the concepts of freedom and informed consent are really grounded in this principle. So when we provide informed consent and individuals sign for different procedures, we're really ensuring that their autonomy to be able to make the right choices is theirs. So when we also think of autonomy, we also think of accountability. So in order for an RN to be autonomous, she must be accountable. He or she must be accountable for his or her own practice. The next, well, when we think about limitations, if you ever think, is there a time when an individual's autonomy would be taken away? So if you think about this for just a second, there are definitely limitations to autonomy. So if a person poses a risk to others, or if they're unable to make decisions for themselves, such as maybe they have dementia, Alzheimer's, maybe they are developmentally delayed, things like that. And when we think of a risk for others, if you think of specific instances, for example, a few years back there was a patient who had active TB, and that individual refused to stay in the hospital and was actually trying to get on an airplane. This individual's autonomy was taken away and was forced to undergo medical treatment, a forced quarantine, and be hospitalized because they were posing a risk to others within our community, within the world. So like I said, the limitations are if a person poses a risk to others or if they're unable to make the decisions for themselves. The next principle that we want to talk about is justice. And so justice is really, just as the slide says, upholding moral and legal principles and the obligation to be fair to all people. So when we think about justice, we're really thinking of the provision 3 that we just spoke about not too long ago. So it's really about RN responsibility. We act as a healthcare advocate with all patients and conditions. We treat them equally and fairly to ensure proper care is being done regardless of how much money they make, their race, their gender, their marital status. It's really treating all individuals the same. Also within justice, there's, as a nurse, a future nurse, it is important that when you see incompetence or an inability to perform evidence-based practice, that you're reporting potentially incompetent, unethical, and illegal practices objectively and as factfully as possible. So an example is if you saw an RN abusing narcotics or believe an RN is abusing, is either abusing or diverting narcotics, that's something that nurses really do need to ensure that they're looking at and watching for, because the prevalence is actually quite high in the medical field. Another example of justice is potentially moving the least critical patient out of the ICU because of overflow. So let's say you have a critical accident trauma that comes in. If there are no beds available in the ICU, triage could be an act of justice to ensure that the critical patients are being cared for. And then when we think about distributive justice, you can read the sign, what it says there, but it really includes equal access to health care for all individuals, whether they're immigrants or whether they've been people living within the society forever. Now, are there any limitations potentially to justice? Making sure equal care. I think about patients who need to have a transplant, And let's say there is a medical assistant, per se, that was diagnosed with diabetes, but this individual refused to get medical help, and they refuse to follow a diet or medication management. Now they present and they need a pancreas transplant. There are very, very strict rules around organ donation and organ transplants, but this patient may or may not be deemed able to receive the transplant because of the non-compliance. Same thing is true for individuals who maybe have severe liver cirrhosis because of alcoholism. They may be denied a liver transplant if they have continued to drink. So there are always limitations. It's just kind of, for the most part, we want to ensure that we're being fair to all people and treating them all equally. Our third concept is beneficence, and it is to promote goodness, kindness, and charity. So it's to abstain from injuring others and helping others further their own well-being by removing harm. So when we think about that, we want to weigh the risks and make sure that the benefits are greater than the risks. So it's really doing good, but it really goes beyond providing just good care. It's about providing that holistic approach, making sure that we consider their beliefs, the patient's and family's feelings, their wishes, and maybe what the family would want in some cases if an individual is unable to make a decision. And sometimes what I've found is that nurses have a difficult time determining what is really good for a person and who can make the best decision if the person themselves are not able to make the medical decision. If maybe a patient is unconscious, things like that. Sometimes what we think is good may not be what a family thinks is good. So sometimes there can be some ethical discrepancies when we think about beneficence. Now, when we think about non-maleficence, it's really the duty not to inflict harm. So it implies we need to abstain from injuring others. So to help others for their own well-being by removing harm. So if we think about intentionally or unintentionally, an intentional may be a patient undergoing a painful surgery, but it really is to remove cancerous growth to prolong his or her life. Or unintentional, and I think that nurses may or may not do unintentional when we're not performing sterile technique on a central line, and maybe a patient becomes septic and their length of stay is lengthened. Another example of unintentional non-maleficence is maybe not reporting unethical practices or substandard practices. We know that this can inflict harm, and if we see individuals doing things that aren't up to standard, then that could definitely be an unintentional non-maleficence issue. Now, however, there are times when we do put patients at risk. So I think of cardiac telemetry unit where I worked for many, many years, and it wasn't uncommon for a patient to come in with severe heart failure, an ejection fraction of 15%, and we gave them high, and maybe have some renal insufficiency with an elevated VO1 and creatinine. Now we gave these individuals high dose furosemide within a hypertonic solution. So could we hurt the kidneys more? There is always the possibility, but usually the benefits of the medication outweigh the risks that individual has to go through. So it's a fine line between making sure that we're doing things for the right reason and we're not intentionally or unintentionally inflicting harm with them. The next concept is fidelity, and that's really the responsibility to keep a commitment. So it's really our obligation to stay faithful to agreements and responsibilities as accepted as part of the nursing profession. So as soon as you accept your nursing report, you've now accepted the responsibility to care for that patient or that team of patients. Now, that means that we need to be accountable for our practice, stay current on our practice, and ensure that we're providing the most evidence-based practice care for the team of patients that we have. Now, nurses, we have many commitments. This includes our commitment to the nurses, our other peer nursing staff, our patients for sure, their families we have commitments to, our other team members, so maybe it's CNAs or MAs or the providers. But we also have commitments to our spouses and kids and to our friends, right? I mean, we work every day, but we also go home to friends and family that we also have commitments and responsibilities to. So that's kind of where a lot of times I think of when we think about a conflict. We have conflicts with this principle, or they can occur because people are placed in situations where they do have to choose between work, themselves, or their home life. I think of back to the 9/11 or in any disaster situation. It's the fidelity to protect yourself, fidelity for your family, the fidelity to the profession. When you think about all those who ran into the towers on 9/11, they had the commitment to their job, and unfortunately, they risked their lives, and some of them lost their lives. So it's a fine balancing act that we have to ensure that we keep a close eye on all of the commitments that we have, and ensuring that we're able to meet those commitments. Now, maybe not every one of us is going to be responding to a disaster, but I assure you that at some point in your nursing career, you're going to be asked to stay. If there's sick calls, things like that. And whether you're working an 8-hour shift and asked to stay for 12, or you're working a 12-hour shift and asked to stay for a 16-hour shift because of staffing, there's the struggle, the fidelity or the commitment to yourself and family, or the fidelity to the organization, or the fidelity to the patient. So there are many things that you have to consider before you quickly just say yes, yeah, I'll work, or no, I won't. Because if you're staying to 16 hours, is the fidelity or the commitment to the patient at the very best that it should be? Are you performing at your best, or are you fatigued? Is your performance going to be like it was when you were in hour 1? Because you will be held to that standard. So just make sure that you think about that before you automatically say, yes, I can stay, or no, I can't stay. Because if you don't stay, are there consequences to that as well? Maybe the patients who are in critical care have a nurse that's got 8 other patients, and is that good either? So there can be struggles with that. The next concept is veracity. So it's really the ethical duty to tell the truth. So we know that the profession of nursing does rank very high for our ethical duty to tell the truth. And so we need to continue to keep that level of trust within the community and within our society. So the RN really should always tell the patient and their family the truth. Patients do have the right to know. Unfortunately, many RNs avoid telling or answering questions or telling the truth if the situation is uncomfortable. Now, I don't mean it as, am I going to be the first one to tell the patient that they have cancer? No. But if a biopsy comes back and the family's asking about it, could I say, yes, the biopsy's back and the provider will be in to speak with you about it? For sure. But if there are other questions that it isn't the first time that something is being delivered, we need to make sure that we're being as truthful to the patients. Some mistakes I see with veracity is, when we actually do commit a med error. So if an error is not reported to the patient or the organization, when I really think about this, the patient is really harmed twice. Let's just use an example. Let's say that I provided a patient 50 milligrams of metoprolol. I was supposed to split the pill in half, but for some reason I forgot to split it in half, and instead of 25 I gave 50 milligrams. So one, I've already harmed the patient, right, by not providing them the correct amount of medication. But two, if I'm not truthful to them and I'm not owning the error that I made, and I don't say, hey, Bob Smith, I inadvertently gave you 50 milligrams of metoprolol, these are the signs and symptoms that I need to make sure that you tell me about. If I don't do that and the patient starts to get syncopal when he sits up really fast, or his heart rate drops a little bit and he's not tolerating it very well, and if he doesn't tell me that, and he gets up and he falls and he breaks his hip because he goes syncopal because his blood pressure dips a little bit, I've now really harmed that patient twice. So being truthful, telling them what happened so that they can be on the lookout and ensure that they are also protecting or looking out for their own health, I believe is key. Now, we talk about those limitations. So is there ever a time where maybe there's some limitations to this? And, I really searched, and I think your book even talked about that maybe if telling a patient the truth would seriously harm the patient's ability to recover and would actually produce greater illness. So an example, if telling a dying child that they're dying against the parent's wishes, that may be something to consider. But one violation of veracity that I frequently see, and it absolutely drives me crazy, is when we tell a patient or a family member or a child that something's true, that something's not going to hurt. So I take my kid into the clinic, they get an immunization. Before the child has the immunization, the nurse says, oh, this isn't going to hurt. Baloney, it's going to hurt. It's going to hurt a lot. But what we do then, especially when we do that with children, is that we then have distrust. The nurse told me, the MA told me, whoever, the LPN told me that this wasn't going to hurt. He or she poked me with a needle, and that hurt. Now, at 5 years old, we already are starting to have some distrust for this child. So, you know what? Yeah, it's going to hurt, but I assure you that the pain will get better with time. Let's make sure that we're being truthful to what's really happening. And then the last one on here is advocacy. So I'm hoping that that's not a new concept, and it's really assisting in navigating care. So patients really depend upon nurses to ensure that they're receiving proper care. We need to be the ones to say, hey, you know what, we need to get pastoral care services involved, or hey, this patient isn't eating very well. We need to make sure that we have nutritional services, or maybe this patient needs a little bit of discharge assistant. Let's get a social worker or a discharge planner on board. So it's really assisting patients and helping them navigate through the fragmented healthcare system and ensure that they are getting proper care. You can take a look at these and try to work through them if you'd like. I'm just going to keep moving. So let's take a minute and talk about ethical theory. So we know that an ethical theory is really a system of principles by which a person can determine what ought and what ought not to be done. And everybody's ethical theory can potentially be different. So the first ethical theory, we're going to talk about two. One is the utilitarian. And so just as the slide says, that a utilitarian is, if you are a true believer or a utilitarian, you are rooted in the assumption that an action or practice is right if it leads to the greatest possible balance of good consequences or to the fewest possible bad consequences. So the framework looks at the good of the general population by assessing all alternative actions that influence the overall welfare of the present or future population. So it's also concerned with the individual, as that person is part of the population, but more or less it's concerned with the greater good of the greatest, so the greatest good to the greatest number of people. And the end result does justify the reason why we chose to make the decision that we did. Okay? So let's just look at an example here. So if we think about a utilitarian, we think about the ER as commonly a type of utilitarian viewpoint. So the ER triage, let's say you have 4 patients that present all at the same time. And you're the nurse, and so you have an abdominal pain, a dental pain, a headache, and a chest pain. So if we looked at it from the utilitarian perspective, the greatest good to the greatest number, the end justifies the mean. How would we rank those patients? Well, obviously, we would think the chest pain is in the most severe, so could be having a myocardial infarction. So the greatest good to the greatest number of people, now it would be him. So number 1 would be chest pain. Number 2 would probably be the abdominal pain, or maybe the headache, depending on what the presenting symptoms were. But for sure the dental pain would be last, because we'd want to make sure that we're triaging them to get the greatest good to the greatest number of people. So the patient who's in the greatest need of medical care is often taken before the lesser patient. Okay? We also know that this is really the strongest approach to that bioethical decision making, because just like I said, which action will lead to the greatest ratio of benefit to harm for all people involved? So let's take a look at an example. Now, I do use abortion frequently as an example within my ethical PowerPoint. It's not supporting how I view about abortion. I just use it as an example. So let's say that there is a single 23-year-old woman who's on welfare, and she becomes pregnant with her 5th unwanted child. If you were a utilitarian, under this precept, an abortion would be ethical because it's the greatest good and the greatest amount of happiness produced by aborting the unwanted child. So if we looked at this, we know that this is a single woman. She's on welfare. She doesn't want the child. So this child, for her, she doesn't want it. The 5th child would be obviously a financial burden for her, and maybe a social burden to society. We could look at this and think, it is the mother's decision, but maybe it's better for the mother's emotional and physical health. Would the 5th child be raised in a dysfunctional situation, unwed mother, economically disadvantaged, and possibly some questionable parenting skills? So a utilitarian doesn't really care about bias or what others think. They really create their own rules based on the situational circumstances. So in this case, the mom doesn't want it. If she wanted to have an abortion, the utilitarian would say, yeah, that's okay, because it is creating the greatest good for her. So their perspectives are always changing depending on the situation. I hope this is making sense. Now, let's flip it just for one quick second. So this viewpoint really could be changed based on the situation. So now let's say this same mother was disowned by a multimillionaire. Maybe let's say this was the daughter of Bill Gates. Okay, I'm just being facetious here, but I'm just throwing something out there. So could the view be changed to keep the baby? So let's say the baby was the only boy born to the family, and he would be the heir to the entire state. This child would then contribute to the greater good of the family and society by being the only male heir. So in that situation, if it was switched, then the utilitarian would say, no, she needs to keep the child. So my point here is that depending on the situation and circumstances that are surrounding the decision or the end result, the utilitarian will always go with the greatest good to the greatest number of people, or potentially the greatest good to the greatest good to the individual in which the decision making is occurring for. So I'm hoping I'm making sense with that. So let's look at some advantages. In most situations, the decision making really is easy. So a follower can justify many of the decisions based on the happiness of the individual or potentially the public. Okay? Decisions are often made around a person's need for happiness. So if you're the one involved in the situation, you are going to do what's in the greatest interest of you and what's in the greatest interest to keep your needs met and you happy. You're not just going to do something that's going to harm you or inadvertently distress you. This is potentially the strongest approach used in bioethical decision making. because the individual determines really which actions will lead to the greatest ratio of benefit versus harm for all the persons involved in the situations. Okay, some theories that a utilitarian nurse may support, because it is affecting the greatest good for the greatest number of people, would be quarantine, right? If you had TB, the avian flu, or some type of pandemic, the utilitarian would 100% support quarantine or even immunization, because it is protecting the greatest amount of people, even if you're part of that. Some theories, this is kind of stretching up, but some theories that an RN maybe wouldn't support is organ donation. I mean, this doesn't happen, but think about organ donation preference. If we chose to only give organs to very intelligent people or those with a great deal of wealth versus the common lay person. So it's always in what's the greatest good for the greatest amount of people. Some of the disadvantages is really what constitutes happiness. So is it the average happiness for all, or potentially the total happiness for a few, right? I mean, it's things, these are all situational, but it's who's determining what's the best for everybody. And really, where do minority groups fit into this equation when decisions are based on the greatest good for the greatest number of people? Are the minority groups forgotten about, or are they represented in the decision making? Does the end always justify the means? So I like to think back, a few years ago we went to Washington, D.C., and we went through the Holocaust Museum in Washington, D.C., and when I walked through that, I was appalled because within there was many exhibits, but you think about if they were a utilitarian perspective, within those death camps there were many medical experiments done on children and adults to help them understand the body better and to help the Germans understand how they could prepare or how they could better make their soldiers succeed in war. So many of the Jewish individuals, children and adults, were subjected to many different experiments, and some of them were submerging in ice cold water to see how long they would sustain in this ice cold water. Some of the experiments, they were removing parts of the brain to help understand the brain better. So, does the end really justify the means? And there again, to what happiness? Were we sacrificing individuals and people to get the greater good? I mean, it's very scary. Another experiment that actually happened in the United States was the Tuskegee syphilis experiment. So between 1932 and 1972, in Tuskegee, Alabama, the United States Public Health Service conducted a study and observed the natural progression of untreated syphilis in the poor rural black men. And these individuals actually thought that they were receiving free health care from the United States government. However, what they were really being done was being observed for how syphilis had affected their body. So, again, in this situation, what is happiness, and does the end really justify the means? Are we sacrificing people to get the greatest good to the greatest number? I mean, that's not good. That's not good at all. Thankfully, in today's day, we now have much more restrictions and regulation regarding this, which is great. But these were just two examples that I thought I would share. So let's move on to deontology. So deontology is really a different perspective for ethical dilemmas. And it's really rooted in the assumption that humans are rational and that we act out of principles that are consistent and objective and compel them to do what is right. So when we think about deontology, the focus is really on duty. Deon, the part of the very beginning part of the word, actually means duty. So when we follow our moral duty, we are behaving morally. And when we fail to follow our moral duty, we are behaving immorally. So all of these decisions are made in such a way that the decision could become universal law. Decisions are based on, like I said, moral rules and unchanging principles. Followers believe in the ethical principle regardless of the consequence of the decision. And it's not the results of an act that make it right or wrong, but the principles of why the act was carried out. Okay? So moral principles are separate from any consequences that may occur. So let's do an example. So if you are a deontologist, and it is obviously your moral duty not to lie, and that lying is wrong, and even if it results in harm to others, lying is still wrong. So if we think back to the Nazis and the Germans, if you lied, or to the Nazis and the Jews, I'm sorry, if the Jewish individuals, if let's say you were harboring, if you were a Jewish family and you were harboring, geez, I can't even get this straight today. If you were a German family and you were harboring Jewish individuals in your house, and the Nazis came by and they knocked on your door, a true deontologist, and they said, do you have any Jewish individuals within your home? A true deontologist would say yes, because for them to lie would be against their moral code. So the end is not, the decision to tell or not tell the truth is not based on the end result. Because we know that more than likely, if I tell the truth, that those individuals that are in my home would be injured, put to death, whatever the case may be. So deontology always is based on morals and doing what is right, regardless of what the end result is. Okay. So let's look at the abortion example one more time. So a person believes in the value of all human life, and therefore this is the principle that drives the decision that abortion in any situation is wrong. So the follower, let's say I was a true follower of deontology. The individual or the follower would have the baby regardless of the situation because they believe that the principle of aborting a baby is wrong, even if maybe the mother was raped, the baby had a known genetic disorder in which the baby would not live, for outside in the normal world, or let's say that the mother had a considerable health risk, and carrying the baby or having the baby would put her in severe risk of death. It wouldn't matter. The deontologist still believes in the value of human life. So some of the advantages for deontology is that they are based, just like the slide says, they're based on principles and will be the same in a variety of different situations regardless of the time, location, and people involved. Okay? They do closely mimic the legal system, so laws are based on rights, duties, principles, and rules. So most decisions err on the side of safety, and like I said, they could be considered universal law. Some of the disadvantages is there really ever an exception to the rule? And what happens when principles conflict with each other? So in reality, there really probably are few pure followers of deontology, because most people will consider the consequences of their action in the decision-making process. All right? And an example just a simple example I think about this is that most people don't believe in violence. Most people know that hitting and their spouse or any type of physical violence is not acceptable within our society. However, many parents still do spank their children. So right there, and I'm not saying spanking is good, I'm not saying spanking is bad, I'm just putting it out there that I may be a parent who thinks that any abuse, physical abuse, emotional abuse is bad. However, I may spank my child on the butt occasionally. Is that really a conflict? It sure could be considered a conflict. I'm not going to go through this group activity, but you definitely can take a look at it. It would be beneficial for you. So one thing that you really need to analyze is, how about you? You must examine your life and its origin, as well as its worth, usefulness, and importance. You really have to understand your own values and first have a good understanding of what values you represent, and then seek to understand the values of others. Because as nurses, just like we said earlier, we need to ensure that we're providing proper care for all individuals, whether we agree with the decisions that they're currently making or not. It is not our duty to say something is right or wrong. We need to make sure that we're providing care at the highest ability. And sometimes that can be different if our values and the way that we believe is different than that of the patient. So let's take a few minutes and let's take a look at some bioethical issues. So the ethics of life and death. We know that many healthcare situations really lack a clear sense of right or wrong. Some of the biggest bioethical decisions really focus on the quality of life. So are we postponing people's life? Is that always right? An example I like to think of is that many years ago there was the Terry Schiavo who was considered brain dead, and there was a fight between the husband and the parents. But what is the quality of life for people? We are keeping patients alive a lot longer than we ever used to, and is that good or is that bad? I think in many cases it's good, but not in all cases do I think it's good. We also have many new life-sustaining technologies. Working in cardiac most of my career, many years ago, if a patient's ejection fraction was low and they were at risk for VTAC or VFib, we just put them on meds and hoped and prayed for the best. Now we can put an AICD in and technically keep them alive longer and sustain their lives. And we also know that there are many, many, many science advancements that are promoting quality of life and the sustaining life. But medications and treatments, but is it always right? Are we making the right decisions for the right reason? And are the families and patients really understanding that some of the medications or procedures, are we really helping them or not? And I think of, at least from a cardiac perspective, there are some patients who need to have valve replacements, and they should have had valve replacements and AVR done maybe potentially in their 50s and 60s, and now they're waiting into their 80s, and they have many comorbidities, and they end up having a TAVR, not an open heart aortic valve, because their risks are too high. So they end up having a TAVR, and their life really isn't any better, and now they have more medical complications because maybe the TAVR didn't go well because they're at high risk. Or, I also think of, we have 80-year-olds who get cancer, and we do everything possible for them. We give them chemo, we give them radiation. But is that really the best for the patient? I don't know. I mean, in some cases I definitely think it is, and in some other cases I see patients suffering and families suffering, and I just kind of think to myself, boy, would that person, would that family have had been better off just to live with the disease and live with whatever great precious time they had left. So it's really, it's unclear, and that's where bioethical issues are really grave. But it is important for each nurse to consider potential ethical dilemmas that you're going to face in your nursing career, how you're going to recognize them, how you're going to handle them, and how they may affect both the patient and the family. So we think of, well, we just talked about those theories, but you have to recognize that all families and patients and yourself have some parts of either utilitarian or deontology ethical principles, and that's what's guiding your decision making or their decision making. And that's why I feel it's important to go through them. Now, are there others? Definitely, but them are two of the bigger ones. So here are the top ethical dilemmas in nursing, and I'm not going to read through them, but you definitely can. So one of the bigger, actually, One of the bigger ones is obviously abortion, and we know that this is a heated topic still today. Um, but some of the ethical dilemmas is really, when does life begin? So when we think about this ethical dilemma, it's kind of looking at the mother's freedom of choice versus the recognition of when life begins for the fetus. Um, we know that abortion evokes very strong emotions in many people. Because of its religious, ethical, social, and legal implications, abortion really does touch everyone. And there really are very few middle ground people with this dilemma. You're either pro-choice or pro-life. So it can get very heated. But we already discussed, but from a deontological perspective, abortion really reflects a basic conflict of rights. So the conflict lies in the, just like I said, the right to self-determination versus the fetus's right to live. So abortion is not advocated, but the right to self-determine is what's advocated for. So when we think back, Roe versus Wade was actually when abortion became legal in the United States, and it was under the precept that under self-determination and the right to privacy that abortion was legal. Ironically, abortion became legal in every state since the United States Supreme Court decision versus Roe versus Wade since 1973. And really, like I said, it really was because of self-determination and the right to privacy. Ironically, when this case started, the woman, Roe really wasn't her real name, but she had had a child or two children already, but by the time this whole thing completed, she'd actually had her third child and is now a pro-choice advocate. So right or wrong, really, abortion does continue to rest with the individual. But I think it is good for you to kind of know where you sit with abortion, especially if you're going to be working in an obstetrics, maybe in a family practice, maybe, with youth, because as I said, it isn't whether you agree or disagree. It is about making sure that you can advocate for the patient. You can advocate for giving them proper information, proper advice, whether they want to keep the child or abort the child. It isn't your decision, but it is good to know how you feel about it. Genetic research really of any kind is very important. Genetic research or just research, I should say, in general. So we know that there are many types of genetic research going on, and many years ago, it was completed in 2003, but there was a Human Genome Project. It was a 13-year project which really identified all the genes and their makeup in the human DNA. That really is what kind of put the impetus to do genetic screenings, prenatal care, adult screenings to determine if someone has a higher risk, maybe with the BRCA1, BRCA2 gene for breast cancer. Now there are genes that can measure Alzheimer's, Huntington's disease, and other diseases that an individual can get. Or potentially, like I said, that prenatal screening, and if there are known genetic disorders that could be inherited to the fetus, and then potentially even providing care in utero for that baby. We also know that there is a lot of fetal research that occurs, meaning taking a look at how fetal cells rapidly divide, grow, and adapt to new environments. And some of the good things that have come from fetal research include vaccines such as rubella and varicella, knowledge regarding birth defects, or even abnormal cell duplication in regards to Down syndrome or SIDS. Now, there's stem cell for sure. There's also in vitro that could be included in this. But what I do want you to think about is, besides genetic research, is that research in the healthcare field is growing. It's not uncommon for a nurse to be caring for a patient who is within a research trial, especially at Aspirus, there are many research trials that are going on, and a patient may be admitted, and even at St. Clair's, I would assume, a patient may be admitted and they're on a research trial in which you have to provide the medication. Oftentimes, just so you're aware that the medication does need to come from home, and the patient doesn't even know whether they're actually getting the legitimate drug or they're getting a placebo. But it is still your responsibility to ensure that they're meeting the requirements of the research trial, making sure that the medications are there, making sure that they're taking whatever it is that they're supposed to be taking. So research, you will see research, if you're not going to be working per se with fetal things or genetic screenings, you will see research in regards to trials that are occurring, or placebo meds, things like that. Now when we think of death, death again is the quality of life. What's the issue here? Quality of life and end of life issues. So just like I said, with advances in healthcare, what is normal, what is heroic care, it really has become unclear. We're really treating patients a lot longer than we ever used to, and like I said earlier, I think in most cases it's good. However, in other cases I think that we're prolonging agony, we're prolonging maybe I don't know, sometimes it's just not good, and I'm sure that some of you have seen some of this while you've been at the hospital. Within this death content, we also think about euthanasia and assisted suicide, which is these new ethical questions. Now, I do want you to be aware that euthanasia in the United States, specifically Oregon and Washington, is actually legal. The only other place that it's legal is in the Netherlands, but it's under strict regulation. And so in Oregon, it's the law is the Death and Dignity Act. So a person must be a resident of the state of Oregon, have a terminal condition that's confirmed by a physician. They must inform the attending physician of his or her desire to die. They have to complete a request for medication to end the life. They have to wait 15 days and then verbally reconfirm the wish to die. At that point, if the MD is certain that the patient is making an informed and voluntary decision, the provider can write a prescription for a lethal dose of medication. And then the provider must also complete and submit a form to the state, and that's really to avoid any criminal or civil liability. So know that in Oregon and Washington this is legal, and we just had that case not too long ago, and I can't remember what her name is, but she had brain cancer and ended up deciding to take her own life. So if you are going to be moving into any of those states, know that this is legal. However, everywhere else it is illegal. It is illegal. This little lady, she kind of cracks me up because she has the do not resuscitate on not only her chest but on her back in case she coded out in public so that people would know her wishes. Now, is that legitimately legal? Not in the United States. It's not. All individuals who are considered a DNR, do not resuscitate, need to have a Wisconsin do not resuscitate band on. But what I do think is that we as nurses need to be advocates for an advance directive for healthcare. So we know that an advance directive describes in writing the individual's choices about treatments that they want, or about the healthcare decisions that can be made if the individual is incapacitated or can't express their wishes. In Wisconsin, an advance directive can be made if they're 18 years or older and of sound mind. So we really need to be advocating for it. Many facilities actually assist, like Aspirus has Thoughtful Thursdays, in which pastoral care and individuals within the hospital help patients complete their advance directives. And if you're sitting there thinking, I don't have an advance directive, I strongly encourage you, I don't care if you're 20 or 48 or 52, everybody should have an advance directive. You could stop watching this videotape today, get in your car, and be paralyzed or be in a coma, and somebody else is going to have to make decisions for you. And I know that I want my decisions made for me by the individual for which I appoint, and for what we have discussed as I want in case something would happen with me. And in order to be an advocate for an advance directives, I think it's imperative that you yourself have an advance directive. Because I assure you, the patients will ask, well, do you have an advance directive? And you can definitely say you do. It's a very simple and easy document to complete. So do take a look at it. So when we think about organ and tissue donation, we know that in the United States there is a widespread acceptance of it, and you can read the numbers there. It is a requirement that if an individual dies within the acute care setting or anywhere, that the OPO, the Organ Procurement Organization, does need to be notified. And at that point, they are able to tell you if the patient is able to donate anything. So there's a couple different types of organ donation. There's the living donor organization. Geez, I can't talk. The living donor donation, which maybe a living donor can is obviously living, but they can maybe give up some of their bone marrow, their kidney. There's the declared living dead donor. So the donor is actually declared brain dead, and they're able to donate their organs, such as their heart, lungs, or any viable organ or tissue. And then there's the deceased, and that's where most of us will have to call OPO, because is the individual a candidate to donate any tissue, skin, their cornea, or do they want to be considered a cadaver, where maybe the medical sciences would be able to use the body for teaching, for teaching. Okay, so the big thing is will you be a donor? And I strongly encourage you to go check out the OPO website. If you're on full view, you can click right onto this link here, and it will take you to the Organ Procurement Organization. In order to be an organ donor within Wisconsin, you really should sign up. The patient should sign up for the registry for Wisconsin, because just the donor dot doesn't always, on the license plate, doesn't always, maybe they don't have a license, or they don't have their license with them. But an organization can go in and look up the registry to see if the individual really wanted to be an organ donor. So if you're considering being an organ donor, or you're advocating for the OPO, please make sure that you tell them to go on and sign up for the registry. But take a look at this website, it's interesting. So one thing we do know about organ donation is it can interfere with organ donation. It's not the individual who's actually donating, but it's obviously the family. So sometimes there's confusion, sometimes maybe manipulation, emotionally charged. Obviously they're very distraught. Sometimes there are misconceptions that maybe an individual will be disfigured because of the organ donation. So a part of a nurse's responsibility is really clear communication with the family, advocating for an early advance directive, and then eventually notifying OPO. Most facilities now will have organ donation representatives, which are nurses who are specifically trained to ask about organ donation, and most of the times those would be ICU nurses or a hospital supervisor. There are also cultural and religious implications that may prevent a family from wanting to donate. And some of the most interesting ones I found was that gypsies, if they're a gypsy, They believe that they need all of their organs for 1 year because they retract their whole entire life within that year and need their organs. Jehovah's Witness, can receive the organ, but the organ must be drained completely of blood. So there are different cultural and religious implications in regards to not only donating but also receiving organs. And then children and ethics. So normally the child's parents determine and make the child's health care decisions. We know that in most situations, the parent's decision will be respected because they really put the child's best interest first. They understand what the child or the patient would really want and what the child has already gone through and really what the child can handle. Unfortunately, there are times, though, when parents are not able to make decisions for their parents, especially if there's suspected or actual physical abuse or neglect. But again, there are ethical dilemmas that occur within children and within the parents' ability to make the right decisions. If you think about some of the ethical dilemmas we had right here in Wausau, there was the case with the girl who had the diabetic ketoacidosis who passed. There are things that happen and we don't always understand, but that definitely could have been a deontological perspective. Think about conjoined twins and the parents having to decide whether to go through it or not, maybe potentially losing a child. So there are definitely ethical debates, ethical issues that 100% surround children, and I will be honest, they are the most difficult ones to have because kids are kids and they haven't lived their life, and it makes it very difficult. So when we think about RN responsibilities, I think it's pretty simple, but it's first and foremost understanding how you view how are you viewing the ethical dilemma? What is your viewpoint? How could it potentially, or how should or should it not affect the care that you are providing? But then for sure the follow-up would be informed consent, education, support for the family, confidentiality, high quality care regardless of your own views or moral beliefs, and then you can read that last slide. But when we think about the ethical decision-making process, we really think of 5 steps. The first step is really not that. So you can read through those questions. But here's step 1, is identifying the ethical issue and problems. So we've talked about many ethical dilemmas that are obviously higher up, but there are ethical dilemmas that you may face every day in your nursing career and that you need to recognize them. So the first thing is to identify them. So collect, analyze, and interpret the data. So what is the issue? Are there any hidden issues? What exactly are the complexities of the situation? Is anything being overlooked? And what does the patient and family want? Okay, so let's say you're taking care of, now this is kind of a facetious example, but I'm going to use it. Let's just say you're taking care of a terminally ill elderly nursing home patient and they're admitted to the hospital. The physician ordered the patient to be a full code, but he didn't speak to the patient, and at the nursing home, the patient was a DNR. Well, that's an ethical dilemma, right? What do you do? I mean, what if something happens? So let's walk through that. So step 2 would be state the dilemma, right? So the statement encompasses the problem and the key ethical issues. So in this case, the ethical dilemma could be that the client's right to die with dignity versus the nurse's obligation to preserve life and do no harm, right? The patient has the right to die, but right now our order currently says that we need to do everything if the patient would code. The third step is to consider the choices. So make a list of reasonable actions, examine and utilize the available resources. So this is kind of those brainstorming activities, and all our alternatives really should be considered. So maybe in this situation, do we perform CPR? not resuscitate the client at all, only go through the motions, seek another assignment to avoid the problem, report to the supervisor, confront the physician, or consult the ethics committee. So those are some of the brainstorming choices that we could have in this situation. Then step 4 is really analyzing both the advantages and the disadvantages of each of those brainstorming activities that we did. Okay, so let's see, if we perform CPR, is this in the patient's best interest? If it's not done though, the nurse isn't following the MD order. Not resuscitating the client at all, well, that could lead to a lawsuit because we're not following orders. If we just go through the motions or seek another assignment, we're really having a submissive attitude, and we could make continuing practice in the institute very difficult. If we report to a supervisor, we could get some action happening there. If we confront the physician, right, initiating the physician might anger them or cause them to distrust you. Regardless, should be necessary. And then consult the ethics committee. If you're unsure, this may be your best option, but it could cause others to view you as unable to try to resolve the problem on your own. These are just some things. It doesn't mean that it's true or not. But a couple other things to make sure that you take a look at is the ANA Code of Ethics, the Board of Nursing Rules and Regs, any legal law that might support the ethical issue, and any organizational or regulatory framework that may also be involved with the decision that needs to happen. And then lastly is really making the decision, so justifying the selection. Most difficult part of this is definitely the most difficult part of the process, because you have to make it final and you have to go through with the action and you have to live with the consequences. So many nurses have a difficult time with actually making the end decision because they're really not sure. It's unclear, it's gray. Ethics is not black and white, it's gray. And so is the decision the right decision or not? But I always say is, make sure that if you're ever in a gray situation, a collaborative decision made by the physician, nurse, family, and client is really the best decision that can be made, so that everybody has a say in what the final decision should be, to try to make it the most cohesive decision. All right, you can take a look at this. I'm going to let you try to figure out what these answers are for questions 1, 2, 3, and 4, and 5. But if you have any questions, please let me know.